Hello, everybody. Welcome to the Benzo Warrior Community Zoom meeting. Today, Benzo Warrior Community hosts Bernie Silvernail, founding member and president of the Alliance for Benzodiazepine Best Practices. We are glad you're here. Bernie will speak with us here on Zoom today. He will provide an overview of the Alliance and their approach to the problem of benzodiazepines. The Alliance for Benzodiazepine Best Practices primary objective is to significantly reduce the number of benzodiazepine withdrawal sufferers by reducing the number of new prescriptions for benzodiazepines and Z drugs, limit the duration of use, and provide an evidence-based pathway for deprescribing. Their focus is to illustrate the problems associated with benzodiazepines, illuminate alternatives to their use, and provide tools for clinicians to assist benzodiazepine withdrawal syndrome sufferers. Bernie will speak with us today about the significant progress they've made and talk about the programs they have underway. He will also include information for those who are interested in volunteering with the Alliance and can share the areas in which they have the greatest need. Thank you, Bernie, for joining us.
Thank you, Lisa, for the nice introduction, and Barbara also for your previous contacts. I appreciate that. And I've run into both of you in the the Colorado Consortium for Prescription Drug Abuse Prevention, specifically the Benzodiazepine Action Work Group there. So I appreciate how active this whole group is, and I'm glad you contacted me, because that's been one of my personal long-term goals with the whole group, is to try to find a way to unite the various working groups for benzodiazepine affected people, and you're certainly among the most active. All right, everybody ready? Here we go. All right. First of all, I was already introduced as being this, but the other co-founder was Dr. Stephen Wright, who has retired from all medical practice now. So it isn't just about the Alliance. It's he just had enough, and he's concentrating on grandchildren and other parts of his life now. So anyway, Steve left us, but we have a pretty good organization anyway. Many of you may know me as the spouse of Carrie Silvernail. She was used benzodiazepines short term, and particularly Xanax and Valium. She used both of them short term, intermittently for Xanax. As part of the withdrawal symptoms that she went through, she was prescribed gabapentin, and the Valium was a prescription for that also. Once she pretty much figured out on her own, like many of you, what the problem was. Not a lot of help from the many physicians that she contacted. By my count, it's well over a dozen that she tried to get help from. But she wound up doing a 3-year taper from that, and did 6 years for post-taper. That's where she's at right now. It's 6 years post-taper. She helps currently with the Alliance for helping benzo injury sufferers, like Dee Foster also does this through Benzo Free. He does a lot more than we do. But anyway, she still has, I hate to report, but she still has bind symptoms. And if you don't know what that is, I'll talk more about bind in a few minutes here. So if you know me because of her, that's her background. Okay, so let me just see if I can get this back to tracking. Here we go. You already heard about our mission, so I've given it a couple of different spins, but the key wording here is reducing the number of benzodiazepine and Z drug prescriptions. Benzos and Z drugs are both part of a broader class of medications called benzodiazepine receptor agonists, BZRAs, and there are other drugs that are in that class too, other than benzodiazepines and Z drugs. So what we're really focusing on is mainly benzos, but whenever we have a chance, we also bring an awareness of the Z drug problem too, because it's basically it's the same receptor sites are affected by these drugs, and from what we've been able to see in the literature, although the degree differs, the effects of the class of drugs is the same. So anyway, what we're trying to do is get it back to evidence-based levels. And we think that's about a 90% reduction from the current prescription levels. As Lisa said at the introduction, we're all about finding an evidence pathway to making all of this happen, including deprescribing. And we have, and we will continue to provide tools for the benzo affected community. So, so we have that focus as well as what our current is. I'm trying to advance, and for some reason I'm not able to do that. There it is. So in summary, we have this split focus, but really, realistically, 80% of what we're doing is what we call front end. We want to change the people, change the practice so fewer people get hurt. That's really what we're focused on the most. We also have a back end focus, which is helping the folks that are already injured by this horrible medication is all I can say. Okay, so I'll just run through a little bit of history. I won't spend a huge amount of time on this, but in 2017, we got together, joined forces. 2018, we launched the organization with a small board and a few advisors. The CMEs are the continuing medical education courses that we provide for prescribers to teach them the problems associated with benzodiazepines and how to limit their prescription and how to help people who are already injured. So that's kind of a summary of what a CME is. So we track that as you go through here. You'll see that we pay attention to that a lot. We took us a while, but we got our first paper published in 2019, and we held our first benzodiazepine symposium that was actually part of the Alliance. The TIBS conference was arranged separately. That was actually hosted by Marjorie Merritt Carmen, who is also a benzodiazepine injury sufferer from Bend, Oregon. She put the whole thing together along with Dr. Wright, and so it was one of those things that was driven by the injured patient community. The same thing with this Arizona Benzodiazepine Symposium, although we, at that point, we had engaged some professionals to help us with that. So that was neither one of these symposia, the TIBS conference nor the Arizona Benzodiazepine Symposia, in my opinion, were adequately attended, is because of the way they were put together. They were both, there wasn't enough lead time to advertise. So we're hoping to rectify that with some of our future work. So anyway, our number of CMEs went up. We got our first grant here in 2019. In 2020, we published the book, which is the best available book on benzodiazepines. It's called The Benzodiazepines Crisis. It does not have a chapter devoted to deprescription that I would advise anybody to use for, for tapering. There is some advice, but it's there. To be honest, at least in my opinion, there are no good guidelines that cover all of the needs for deprescription yet. So that's one of the reasons we're still working on that. We published a few more papers, a whole bunch more education, and we released our deprescription tools. And so in 2021, we grew the board and the advisors more. The FDA invited us to submit a project application, and we did that and did a couple of papers, more papers. So far this year, we've put a focus on increasing our board because we had so many medical professionals on the board before that none of them really were focused on all of the other things that it takes to put together a successful nonprofit. And so we increased our board with those other skill sets. And most of our advisors are still in the medical realm. Most MDs, or some DEOs, and several pharmacists at this point. The FDA contacted us again to ask us to subject another project. It's basically a grant request to them. And we had a good beginning of the year. We've published 4 papers this year already, and a few more continuing education things. And internally we developed this thing called work groups, which will allow us to be much more productive. So that's an internal productivity measurement. Let me pause for a sec. I didn't say this at the beginning, but you're welcome to interrupt me and ask questions right in the middle of this. So I'm fine with that. We can also do the collection of questions, and I can answer those at the end. I'm happy to answer questions in the middle. And what I'll try to do is pause at least at the end of each slide to give you a chance if you do have any questions to ask those. Okay, so be prepared. The whole adventure that we've undertaken here in the world of benzos is based on these values here. So I thought I'd just spend a second mentioning these. They're very simple. We tried to keep them as simple as possible. It was to minimize the harm, and everything we do has to be evidence-based. And every sufferer deserves to have their story told. So we want to collect those and disseminate those and make sure that you're being listened to. And by the way, you have been listened to by the FDA. They've kicked into a much more receptive mode in the last couple of years. And then the last one is everybody deserves respect, both the sufferers and prescribers. And so as a result, for example, one of the direct results of this last value is we don't do blogs on our site. We just don't have any mechanism for that at all. Although in the way it's set up, some people can send us blogs, but we never post anything. And the reason we don't is we don't want to get into the whole concern of filtering for doctor bashing, because that'll take some effort, and we don't want to get into some sort of arbiters of what's right and what's wrong in that area. So we just don't. So we're not a social media site that connects everybody together in that manner. We believe our job is more focused on the front end piece and then providing tools rather than providing direct support, even though we do some of that. So can't say it's 100%. Any questions? Okay, so here's our current board. The note about Hunter comes up here in a second, but so all of these folks are listed on our website. You can see them. I won't go through them in detail here. We just added 5 new directors at the beginning of the year. Here they are. You can see that the new ones are less in the medical domain, except for one of the pharmacists, because they're helping us fill out our ranks. And then we have 1 employee, just Hunter is the only one. Okay, and here are our advisors. They're all volunteers, but if you look across this list here, you can see that they're almost all MDs. We have an MBA, a pharmacist, and DO. Yeah, there's an osteopath, and Jane Violet, who is a professor of medical communications. So some of these names may be familiar to you. Jocelyn Peterson, for example, has been in the benzodiazepine community for a long time and has her own YouTube channel. And the Whit Durings and let's see who else. Michael Bohan those are all 3 of those are also advisors for the Benzodiazepine Information Coalition. We also have.
We have a question from one of the members. Harold asks. He says, "I'm very interested in designing and delivering a CME. I'm not a doctor. Can you explain the logistics?" Well,
not being a doctor may be a problem. If you're another medical professional, you need to be some kind of a medical professional to be able to put something together that actually gets delivered as a CME. So I can address that right now if you're okay with that. CMEs have to be certified. That's the C in well, they're continuing medical education, but they all have to be certified. And to do that, there are companies that grant CME certification. And so whatever you present, you have to send to them and they review it. They have a board, they have a team of medical professionals in the case of medical CMEs, and that review this, and they have to put their stamp on it and say that it's it meets their requirements. So I perhaps spoke hastily and said, when I said you have to be a doctor to this, you don't necessarily have to, but you have to pass that kind of review. So it has to be at that level. Many of the folks that are on this list here and the medical people who were in the previous list have created their own presentations on benzodiazepines. And when they deliver them, whatever group they're delivering them for usually wants to try to make sure that they're delivered as CMEs. For example, Dr. Chris Blazes, he's in the last list. I'm in Portland, Oregon. He's with the Oregon Health Sciences University, which is our biggest medical system here, and it's an educational system also. And he got interested in benzos years ago, and he started delivering talks on this, but he wasn't really well received until he was doing grand rounds talks, which is part of the educational curriculum. And once they authorized CMEs for that, his audience increased and his, if you will, his credibility increased. So whoever wants to talk about this, please send me the note and I can give you more details on it. But I think rather than burning up all the time here, that's kind of how it proceeds. Okay. This is a slide that talks about what they are, what's the problem. This is not to teach you guys anything. This is simply to show you that if we have to do a super condensed version of what are benzodiazepines, we use this slide, which includes this rough model here in the middle. So you probably have all seen this kind of thing before. We have our links to our website on the bottom for withdrawal and for bind. Should I spend a minute talking about what bind is, or is everybody familiar with that?
Yes, if you'd like to go over it briefly, Bernie, that would be helpful.
Okay. We're actually writing a paper that I'm really excited about right now. It describes what bind is, and it describes the evidence for it, which is probably even the more important piece of it. So yeah, we have this paper almost ready to submit for peer review. So it's our third paper based on a set of peer review, or excuse me, a set of survey data that was collected by the Benzodiazepine Information Coalition back in, starting in 2018. And so we published one paper. We have a second paper that's is in second round of peer review right now, and then this third one that's going to go into peer review in a week or so. But anyway, what is bind? Bind is a name that all these groups have agreed to use for describing particularly the post use of the drug period, although it can extend back into the use of drug period. So there are many names for this. There's about 15 of them that we catalog for trying to describe the continuing problems associated with benzodiazepines even after you completely discontinue, and even after the drug is completely out of your system, which depends on what type of benzo that you're taking. So that's really what it's focused on, is the injury that persists after you discontinue. However, you can also have bind during the discontinuation phase, as in when you're reducing your dose and you have so many more symptoms than you had before you began taking the drugs. That's still part of the bind piece here. So there's a bit of overlap with the withdrawal description too. So that's a quick description. There's also you can see the link there. You can go to that and get what we've written up. It's about a page. That's it. And because several CMEs have been delivered since we started working on this concept of bind, which is now going on about 8 months or something like that. And since these CMEs were delivered, we wanted to steer the medical professionals to a place that defined what it is. So it's located on our website right now, the definition of it. And as soon as we get the paper released, we'll change that connection to be the paper, because that obviously has much more definition than this very simple one-pager that we have. Okay, so I wanted to focus just a second on this rough model. Now, and when you go through the literature, you find completely different numbers for each one of these things that are where the words are, not the arrows so much. We know one follows the other, but whether it's half become dependent or nobody becomes dependent or everybody becomes dependent. There's a spectrum in the literature. This is the officially published medical literature that is pretty broad. It's almost that broad. It certainly is to the withdrawal piece. Within the definition of withdrawal, there are published papers in journals like the New England Journal that say everybody suffers this, and there are papers that say nobody. So it's a wild west in terms of the definition of who suffers from what. And so that's one of the reasons we're excited about publishing survey papers, is they help pin down the numbers, but it's I don't want to say contrived, but a biased study, in the sense that it was only answered, we only solicited for answers, and we've only received answers from people who have been affected by benzodiazepines, so injuries. So it's not a fair study, and there has never been a fair study that takes a random population and subjects them to benzodiazepines and then sees how many people actually become dependent, how many suffer withdrawal, and how many suffer bind. So that hasn't been done, and I proposed at least 3 variations of this to different groups of medical professionals, and in each case they said, you can't do that, it'd be unethical, which was to me a bit ironic, because that's exactly what's happening in the medical community. The docs that are not benzo wise are basically doing a random uncontrolled trial, is my viewpoint. But that's not how it works. You still have to get it through ethical review board to be able to do such a study. So we're looking for other ways of getting around it, and the patient survey is one of them. There are a couple other things that we're doing. All right, so anyway, that's the rough model that we're using, and you're welcome to steal that. It works well for communicating the basic problem. It's not necessarily the best for talking through the details with medical professionals, because they'll want to know the exact percentages for each transition and what your references are. We have resources for that. Okay, so what are we doing about bind? Any more questions? I should pause for a second here. That was the end of that. Anybody have any questions on that model, actually? I'll go back to it.
I think what we'll do, Bernie, is hold the questions till after you speak.
Okay.
And then we'll vet the questions and share them.
Okay, fair enough.
Yeah.
All right, appreciate it. All right, so what are we doing? We have been and continue to train prescribers. You saw the CME list earlier, and we have a bunch of canned presentations that are available on the website, and some of the people who have presented at CMEs have wanted to keep theirs as proprietary. So they're willing to share them. They just don't want them posted on the website. So we're training prescribers. And there's one 4-part training that was just done by the Colorado Consortium, and so I listed a connection for that, a link. So that's one that we'd recommend. There are a bunch of other ones for different things. We have a whole list of tools for patients, so I suggest you take a look at that if you haven't already. They're mainly, if I'm honest about it, most of these tools are targeted at taking a hostile prescriber or just a neutral prescriber who doesn't understand benzodiazepines and trying to convert them to be your advocate. And so it's a stepwise process. There's, I think, there's four primary tools and then a couple of communications tools and a tapering tool associated with it. And so that's the idea, is to get your prescriber to be your ally rather than have an antagonistic relationship with them. That's the main thing. And I understand some of you folks have used that and may even have some feedback. I'd love to hear that. We're following opportunities as they evolve. So I'll talk through these a little bit. The FDA, we originally approached them 2 years ago. Almost 2 years ago, with a proposal for what's called a Safe Use Initiative research program. And the idea was that we feel we've done enough research work to collect the evidence that shows that benzodiazepines are harmful, and what we want to do, in many cases, they're harmful. So what we want to do is try to proliferate that message among the medical prescriber community to get them to slow down on the prescriptions to where they're at appropriate level. And so we articulated that to the FDA. They came back and said they liked what we had proposed, which was an educational program based on these same CMEs that we're talking about, and some of the tools that were developed also through the Colorado Consortium. And so we were doing a blind controlled study. That was our proposal to the FDA, $600,000 2-year study. And they did not grant it to us, but they gave us some good feedback about why. Sydney's coming back in, okay. They gave us some good feedback about what needed to change for us to be able to get to the point where they'd accept a proposal. So that's what we're in the middle of doing right now, is writing another proposal to the FDA. The last one started out, it was a 10-page proposal to get them to look at it and to have us advance to the second stage. The proposal that we finished with that they wound up rejecting was over 100 pages. So it's no trivial amount of effort to put this together. And these are all medical professionals that worked on it, plus myself. And Doreen Chervin, who's a master or PhD public health person. We have the equivalent thing going on with the Agency for Healthcare Research Quality, AHRQ, and so it's in both cases we start with a request to them, and they've come back to us and asked us to submit something. So that's a good trend. We want to work cooperatively with them, because when our original charter, when we put this whole group together, the Alliance, most of our projects were antagonistic to all of these agencies because we just weren't being heard. And since they're listening now, maybe not enough, but they're listening, so they can be sources of funding and sources of publicity for moving the needle on reducing the number of people that get injured. The U.S. Deprescribing Research Network, which is a nonprofit, it's not part of the government, but it's a nonprofit that's funded by the government, so very similar. They have also contacted us to submit a proposal on deprescribing. And we haven't committed to that yet. We're not certain we're going to do that, because that, again, is a back-end type of energy investment, and we're trying to solve the problem at the prescription level, the front end. So we're trying to strike that balance where we help people and yet try to stop the negative flow. Oops, I went the wrong way there. So I have to figure out how to get past this. There we go. All right. And within our group, we're creating new direction through our work groups, and we're trying to follow our strategic plan, which is really where I'll get into the description of what we're doing here. So, strategic plan. Yeah, it's like a 35-page document that we have. We started. That's one of the first things we put together as an organization, and we update it periodically. So we want to try to leverage everything that happened in the opioid world forward. And that includes increasing publicity, getting the docs to pay attention to the FDA's warnings on benzodiazepines, et cetera. And again, our focus on stopping the injury and not fixing the injury. So, so that was like our strategy part of it here. Our programs are fairly large and expensive. There are 6 of them that are defined so far, and are defined at this point. A large expensive program is getting an agency to develop prescription guidelines. These are decidedly difficult things to do. One of them was a deprescription guideline. We had that in as a program. It's still there, but the FDA approached us about a month and a half ago and asked us to submit a bid for developing prescription guidelines, deprescription guidelines. Well, we took a look at this. They were offering $2 million over 3 years as what it would take, and they had several pages. I think there were 6 pages of technical requirements associated with such a thing. So we responded to it with a letter of intent, as did several other organizations, and then we met with the FDA. I think they had 12 FDA and AHRQ people and National Institute of Mental Health people in the meeting. And we went through what it took to do the program. And by the time we got down to the end of the discussion, it was pretty clear that nobody was going to submit a proposal. We felt from the Alliance's viewpoint that amount of money and that amount of time just wasn't enough to develop a deprescription guideline. And we approached a couple of companies who do guidelines. They do medical guidelines for, I mean, that's their career. That's how they earn their money. And they took a look at it and said it'd be more difficult because of all the requirements. Like I said, there's 6 pages of requirements. So, and we contacted all the other groups that were in that meeting, the non-FDA folks, and when there were only 2 other ones. The other 2 said that they were not going to submit proposals, and we weren't either. So I have no idea how this is going to turn out. It's the proposals are due. I think they're past due now. No, they're due at the end of this month, and then within 6 weeks, the FDA is supposed to respond. So technically, within 6 weeks, we can contact the FDA and find out if anybody actually did this. So, like I said, these are larger and more expensive programs. That's the bottom line on that. We're also working on a bunch of projects, and I said over 20. They have more or less a 1-page summary. Some have 3 pages, some have 3/4 of a page. A typical project for us was like delivering the book. That took 1 year and 12 MDs to do, and none of them got paid. So that was a pretty good deal for us. We got the book out of it, and we also were able to make good contact with some new MDs who then act as liaisons to us, and one of them actually joined our group, but most of them haven't. They're people that we go to for their particular expertise. We have delivered all these technical papers I mentioned earlier. They're also listed on the website. I should talk about the ones we're doing now. There's I mentioned the one on bind. That's the one that we're very actively engaged in. I'm not sure if everybody knows of this other group. There's another medically oriented benzodiazepine group. Some very senior people in it, and I think there are about 12 docs in it, international docs. They're called the International Task Force on Benzodiazepines, ITFB. Well, these folks have aligned themselves against all forms of antidepressants, the whole series of them, the whole class, all the various classes. So they think antidepressants are bad, and they think that benzodiazepines are good. With some very senior people, as I mentioned. So they publish periodically. And so a couple of the publications we're working on are refutations to what they've published. And one is a commentary and another is a whole review article. And those both will be coming out pretty soon. So we're in the submittal process on both of those. So it's at that level. Not only do we need to emphasize what the correct information is about benzodiazepines, there's actually this group that who are mostly psychiatrists who claim that benzodiazepines are far less harmful than antidepressants. In fact, some of them have claimed they're not harmful at all. And interestingly, they cite the literature they cite is the same literature we cite for harm. So they're misquoting it is the bottom line. And so we're going to try to put an end to that. If you think of it from the medical care provider's perspective, a lot of these guys have been around for a long time. You know, they've been prescribing benzodiazepines for 40, 50 years. Some of them are over 7, well, at 50 maybe a stretch, but 30 to 40 years. And so they have a lot of their life wrapped up in this, and they've also written papers on these things. And so it's really tough to get that group to change their behavior. So we've tried it by direct contact. I'm in direct contact with a couple of the members, trying to persuade them to move away from the support that they have for benzodiazepines. So that's in a way another project. We have other CMEs that we're actively working on. So there's three of our advisors regularly deliver CMEs and one of our board members. So that's kind of the direction we're moving here. All right, and we have a whole big thrust working on developing partnerships with the various federal agencies here. All right, the second part of this is becoming better partners with the aligned groups like the Colorado Consortium, support groups such as you folks, the Benzo Warriors group. There's a group of epidemiologists who have focused on benzodiazepines, and we're in good contact with them. And I think at least 2 of them are nudging their way to becoming either advisors or shadow advisors with us. And there are other pockets of medical expertise that we're trying to develop, or we have developed partnerships with. So we're still working on that. Now, these last things, let's see, the use of publicity to drive policy, membership, and fundraising. We haven't really done much publicity. We've focused very little on that. We do have, you know, a YouTube channel and Twitter and Facebook and Instagram, but we don't really do much. We have our hired person posts there at least once a week, but not nearly enough, in my opinion, or most other people's opinion. So that's about it for publicity. And we've done, in 4 years, we've only done 1 publicity release, and that was around the book, at the time we released our book. So we're not doing nearly enough there, and we're at a point now where we've got the evidence base in place, and we're planning on moving much more actively in that area. Okay, continuing to help bind sufferers as much as we can. Let's go. Whoops, I just dropped one there. There we go. And then embrace the opportunities for, like, we got involved with the deprescription guidelines. They know who we are. We also offered to provide them connection with the benzodiazepine injured community, because that's part of those 6 pages I mentioned. They had several milestone or several deliverables that had to be delivered that required connection with this community. And none of the other groups that were looking at doing this job had any kind of connection with the community. So I mentioned the ITFB articles, and what's this bottom one here? I'm bouncing off of that for some reason. Oh, the state level benzodiazepine legislation. So you're probably, some of your members are probably aware of the Massachusetts attempts and at informed consent, requiring informed consent. And Colorado has had some success with getting some funding specifically for benzodiazepine education prescribers. And so we're looking at something similar, like if we can spread that effort to other areas. Okay, so this next page is just, there's a lot of stuff on here, but I just wanted to show you that we've gone to this work group structure, and we have basically a page written on each one of these. There's a sentence for each one, and there's a lead person, a director or two that's in charge of each one of these areas. So these are the work groups we have right now. I'll just scan through them. There's education, medical education is the first one. The second one is how do we engage pharmacists who actually have a fairly good track record, at least in many people's experience, in terms of knowledge of benzodiazepines, but how do we engage them more? The third one is actually developing a set of prescription guidelines. The fourth one is setting up a conference for benzodiazepine best practices, and we'd hope to start in 2023. The time window for preparation for that is narrowing quite rapidly, so I'm not sure we'll get to a multi-session best in practice type of conference there. We will have multiple sessions where we train prescribers, but will it be a full conference? I don't know. To me, my personal goal is to have this conference that we're talking about, be one that's not just for medical care providers, but that brings the user community, you folks, the people who could come in and talk about their experiences and have a chance to influence the direction directly. So, and a significant number too, not just one person who comes and tells their story, like Dr. Christy Huff has done several times for the Benzo Information Coalition. We need a larger representation. So, and these other things pretty much mirror what I've already talked about in terms of what our strategic plan is. So, getting better at those things. Okay. So here's a list of what we have the most need of right now, because we operate on. We have yet to get a government grant. We've had a couple of other grants, total of across the last 4 years of $40,000 in grants. But to be honest, those were what I call push grants. The reason we received those grants are a benzo affected individual in each case got in touch with a grant making body and said, you need to help these people out with a grant. And so the grant making body got in touch with us and said, you know, what do you do? How do you do it? And how can we help you? These people want us to push money in your direction. So that's what happened with them. And that's not enough to, you see all the things that we're trying to produce and have produced. It takes a lot more money than that. So, so we need a lot of help in that area. It's the bottom line. Social media, we're very weak, and we have irregular content there. I think Hunter is doing a great job, but it's more than what one person can do while they're doing a whole bunch of other things. So our website, it needs an update. We're in the middle of doing that right now. We hope to flip over by next month to a new version of the website. But the content is it's not to the level that we believe it needs to be. There are plenty of areas to get improved there. And then publicity, I already mentioned that. We're pretty weak on that. And it's interesting, we have quite a fairly good group of people who have volunteered to help us, but we don't have a coordinator that is looking into how to best use those people's talent and to provide a meaningful volunteer position for them and to help the Alliance.